Well, I think you have some questions and conversation for me. Do you want to go into those?
I do. I want to talk to you about what I call the clinical labor force. I'm going to include techs, allied health, nursing, physicians, APPs, CRNAs. I'm just going to call that the clinical labor force. I have strong opinions and I hope informed opinions on kind of what's happening in the labor market, but boy, I kind of think you do too. So I'm interested in a lot of your opinions on that market. So what have you noticed about organizations, clinical labor workforce strategies that make the biggest difference between a high-performing organization and an organization that's maybe not performing as well? And it's easy, I think, Christy, to say, well, hospitals that pay the most, or hospitals that are in really well-insured areas, or hospitals that are in really desirable locales to live in, have the most success staffing their departments. I haven't experienced that to necessarily always be true. There are hospitals that rarely use alternative labor solutions like locums and temp staff that are in really not desirable places to live in the country. And there are hospitals in Florida and California and Texas that struggle perpetually. How do you, as someone that's kind of worked on the fulfillment side in a recruitment role that's charged with keeping the medical staff primed and operating and full of talent, how do you explain the difference between a really well-run and high-functioning organization and maybe one that's struggling a little bit more? What have you noticed the commonalities are?
I mean, you kind of touched on this at the beginning, but it's about transparency and then integration. So it's great you could bring a surgeon in, or you have that key component of a provider in place if you don't have all those other people that we've mentioned throughout the call. So sure, it's one surgeon, but you probably need about 20 other people to make them successful every day. And that's down to like the billing and coding person or even transcription to make sure that you can get paid on their services. So I think since it is such a highly complex environment, you have to make sure the right people are talking all along that way. I used to love when I worked in the hospitals to spend time like with the nurse coordinators and the people who had to move all the nurses around on the staff boards. Back then, it really literally was like a board. I don't know that it was even in Word at the time, but now we have these technologies and solutions that can help. But for me, it is moving into that integrated, probably supported by some type of technology just to make it easier. So we're not using some big dry erase board to move people's names around, but then making sure those key people within that are connected. In hospitals, oftentimes you are set up in service lines, which is a great benefit. So the cardiovascular service line, usually that leader has that tech team. If they needed EKG techs, they needed echo techs, the ultrasound techs, they needed all those people for that one cardiologist to be successful in that day. So within that staffing continuum, I think it works best if you roll a lot of that together because they are so contingent on each other. You know, I think for that super high performer, there's probably a component of EMR in there somewhere. Again, from a communication standpoint, to know, oh, this happened with this patient, you know, those types of things versus trying to gain all the knowledge, or the worst thing, re-asking the patient. Every single person that engages with them re-asks them the same thing. So I think that goes back to transparency, but the EMR, even though it's a love-hate, it's vital to make sure that folks can communicate in that way.
How the organization structures itself and categorizes its workforce, you mentioned service lines, is key. And I think this is where you're going, pairing a recruitment team around a service line that recruits it from the bottom of the stack to the top, providers, techs, everybody kind of working to understand, again, I may bring this physician on, but they're not going to be productive or useful in their role, and they're going to leave after 2 years if we can't get EKG techs and sonographers and all the different things that support them in clinic. And then you're back to square one and you're recruiting again. Talk to me about retention. I believe pretty deeply that employee value to an organization compounds over time. I think if Christy's really good and really smart and super skilled, she's pretty good on day one. She's really good on day 100, but man, she's really good at day 1000. And I talked about it earlier about my feeling of the provider pool being sort of permanent at some of these institutions, and everybody around them, nursing, administrators, techs, everybody else, maybe being less sticky. And I was one of those administrators. I think the longest post I held at an organization was about 5 years, which in terms of physician years, not really that long. That would be a short stint. How do organizations that are successful capitalize on that employee value compounding by keeping people in the seat for longer? To me, that's been the biggest challenge that I've noticed is they develop these workforces that are really large. They put them into 10, 20, 30 job titles, and then they have to treat everybody exactly the same. And as a result, the high performer gets a 2.5% raise and the low performer gets a 1.5% raise. And neither one of them are happy with that. And there's all this churn. But again, some organizations manage it effectively and some don't. How have you seen in the recruitment side and kind of the HR world, how are the high performers differentiating themselves and preventing that churn?
As an organization, if you aren't doing some of these key things that we'll talk about, those high performers have lots of opportunity to take their expertise somewhere else. So usually what I would ask recruitment teams is, what would it cost us to replace that expertise and experience, that highly skilled knowledge of how our health system runs? And I don't think it always comes through directly in compensation. It can definitely be, oh, would you like to do your master's? Can we help support you? Can we maybe pay for half of it or something like that? Like, I always found the more education or professional development, and then even internally, like that personnel development, that becomes sticky. Again, I think it goes back to those relationships that you've built with folks where you can't just throw them a pizza party and you can't just give them a 3% raise. It really, really has to be that intentional growth. And you have to be okay that as a leader, like, I'm paying for them to grow and they might leave. You have to be okay with that, because what if they don't leave? And now you've grown somebody, right? So do everything you can to support them. It's usually financial, because it's usually paying for a program or a class or a new skill set, but it pays off tenfold. I completely agree with you about how exponentially employees' value grows over time. And to see that is to really go put that job on the market and go try to find somebody with that skill set. And you'll end up paying them maybe double if you can find them.
You end up paying them more, but you lose. Healthcare is provisioned at these hospitals 24/7, 365. The engine is running, and you lose progress and advancement during that interruption. So it's very difficult to quantify. So I want to read you a couple stats, and this will paint a picture for, I think, kind of what we're talking about. So these are projected surgeries across the United States for the next 5 years. 2024, we're projecting the United States to do about 51 million. Next year is 52, 53, 26, 54, 55, all the way to 60 million in 2028. So 20% growth in surgical volume over the next 5 years in the country. So we know demand is going up. The average age of American citizens is going up. I think 1 in 5 people are going to be over 65 in the next 5 years. Demand is going in a certain direction. I'm going to read to you some workforce stats. There's 28,000 new medical school graduates annually. There's only 19,000 residency spots. So there's about 9,000 physicians that don't get matched on an annual basis. How many do you think are retiring every year?
Well, I do kind of know the numbers, because I was just reviewing the AAMC numbers for physicians and the age gap. So basically, I think a third of our physician workforce will retire within the next decade, if not sooner.
So the American Medical Association is estimating that 12 to 15,000 physicians retire annually. So if there's 19,000 new docs trained every year and 12 to 15,000 are leaving the workforce, there's a net new of 4 to 5,000 new docs a year. But healthcare is growing as a percentage, 5 to 6% annually, demand is. At the same time, we're creating about 40,000 new APPs a year. I think probably 10 or 12,000 of those are retiring. So the APP workforce is growing faster than the physician workforce. The physician workforce is growing slow. Neither one of them can keep up with the demand that is growing at the same pace as demand. It's creating this pressure, and it's making organizations behave differently, right? They're using their workforce differently. Part of kind of my question for you is, I have felt that the country is as a whole kind of pursuing alternative income opportunities. The gig work economy is getting all the headlines, right? There's the Uber stuff where people are making 50, 60 grand a year and say, gosh, I can show up to this office and sit in the cube every day and make that. Or I can take Uber rides at night. I can DoorDash over here. I can go moonlight for my cousin that's doing this. And they kind of find different ways to earn a living. I have viewed locum and 1099 work as a tool in a provider's tool belt to start living their life that way, where maybe they don't have to be a full-time employee. They're a part-time employee and they do a week on, week off locum opportunity and their income remains about the same. I think organizations that are going to be successful dealing with this scarcity of resource in the clinical labor market are ones that are deploying different types of tools to help them supplement their labor force. Has that been your experience? And what are some of those levers that the forward-thinking, sort of sophisticated organizations are pulling?
It has been, and definitely some of the organizations I've worked in from way, way back in my career already had those APP components integrated or other clinician models, not just the physician. Physician is very important. They do great work. But making sure you had those other care components. For me, you want everybody operating at the top of their license, or if they're unlicensed like us, at the top of their skill set. So I always found where you get to a comfort level with that, either with integrating APPs or other care team members, kind of just making that a standard as you go through. I think we saw at SIA last year just the amount of physicians who are interested in locum tenens work is a very, very high percentage. I would tell my recruitment teams, our number one competitor, first telehealth jobs, then locum tenens jobs, and then anything else that's not 8 to 5, Monday through Friday, 2 nights a call a week. Like when you really go and strip back what the schedule is that we're asking for these folks, who wouldn't want to do locum tenens work or telehealth work? I mean, I work from home. I think you work from home. This is what's being desired. And we're definitely seeing it out of med students, residents, the folks coming out. They want that balance in their lifestyle. And so they're raising their hands more quickly to have control over that, which to me means 1099, PRN, gig, whatever, it ends up being locums type work.
One of the things I've noticed that some organizations tend to think locum as a 4-letter word and others view it as a tool in their tool belt. I think 86% of hospitals in 2021 used a locum tenens. So it needs to be a lever that's controlled and that's used and that is viewed as a positive resource. And thankfully, I've served a couple institutions that have used it as such and used technology and used panels and used different strategies to supplement their permanent teams, and sophisticated physician recruitment departments that are selecting the agencies that they work with, surgeons. They have a lot of say and a lot of influence, and I think rightfully so. That's kind of one of the questions I wanted to ask you. We at Royal Surgical, I'm a former administrator. I've got 2 partners that are former practicing cardiac surgery PAs, so they're former clinicians. And then we've got another partner that's founded the firm with us that was a lifetime recruiter and spent some time at some pretty large, reputable locum shops. We feel like we're doing something a little bit differently, that we can empathize with both the plight of the provider organization and the difficulties that you and I have talked about, staffing and keeping their lights on and doors open. And conversely, we can talk to the providers at a level that I think is unusual in the recruitment space, because folks that lead our recruitment teams are clinicians. So they understand pretty well what the typical clinician's experience is and what they're looking for. We think that's unique and special, and our moms really think we're smart. What I want to hear from you is someone that's been on the other side of the fence and sort of has more experience on the provider recruitment fulfillment arm of employment organizations, where I don't have as much. What do you view from your perspective as being a high performing asset in terms of a locum company versus someone that maybe isn't as an effective partner? What's the difference between kind of a high performing partner and maybe ones that you don't like as much?
The high performing partnerships, really, that was the key, is it was a partnership. They understood our organizational culture, or even within those hospital facilities they were serving. For me, it was more about being transparent about the job and making sure they understood this is what the clinician's coming into, because I have gotten that call before. The clinician came in, it is not what they thought it was, so you quickly have to figure out, okay, well, what work environment did we sell them on? And so that's a really bad feeling because then patient care gets compromised. So for me, it really becomes that partnership with the agencies that you choose to work with. So you both have to lean in together, share what it is you want to get out of that relationship, because it isn't just about paying them big checks. You want to make sure that ultimately the patient is served. I would often go talk to some of the large recruitment teams at the locums agencies just to give them an understanding and a heads up of this is kind of how we work culturally. This is where you need to light fires or things get critical, but making sure they had kind of key contacts along the way so that the agencies wouldn't get frustrated with our internal teams. Because what I would remind them is locums was almost no one's full-time job in the organizations that I served. So reminding them how to best engage and then equally elevate issues that they have. Because over time, if you as a hospital, a healthcare organization, if you're not responding to those agencies or those candidates coming in, if people aren't calling them, those agencies stop working. Like your candidate pipeline will go away because they don't want to work hard for you if you're going to let their candidate die on the vine. It's the same for perm recruitment. If the next person isn't calling the candidate, they never come for a site visit. They're never going to sign a contract. So it's a lot the same, the perm and the locums world. It's communication and then, really feeling out what I need from this and what you need from this and making sure that you can get on that level playing field.
Did you know PracticeLink is not only home of the most widely used online physician job board, but we also have our own magazine? PracticeLink magazine has not only won several awards, including 2 ASBE Awards of Excellence in 2023, but it's also completely free. Over 375,000 physicians and residents receive copies of PracticeLink magazine each year, and you can too by visiting practicelink.com/magazine. That's practicelink.com/magazine. Thank you for listening. Now we'll return to the podcast.
You didn't mention fill rate. You didn't mention any particular specialty. You didn't mention cost. You talked about a partnership, and it reminded me of the transaction question that you asked. And I think if you were asking from my perspective, what relationships are best, where do we work the best? It's with facilities that treat us like an asset, like a partner. What you get in is what you're going to get out. And the last kind of thought that you dropped was about your candidate pipeline drying up. We see most locum jobs across the country. There's a pretty big difference between I can tell within 15 seconds of reading the job description how fillable it is. And there's an opportunity, I think, from an in-house team's perspective to lean on people that are in the outside market and actually take their feedback in. And it feels self-serving to say, hey, this bill rate's a little light. In reality, didn't you post a job because you wanted it filled, because you have a need? And I think that dialogue only exists when the hospital team allows it to exist and wants to be a part of the conversation. That's when it works best. But I recognize that sounds a bit self-serving to hear that perspective from me.
I didn't ever ask people to make decisions based on the cost, because you will get what you pay for. And I think you have to always remember you have people's lives in your hands. Even if you're the person clicking accept on that provider, you better have done some due diligence in reading their CV, calling them, doing an interview. Anytime we were bringing in temporary staff, especially surgeons, the high-performing organizations I worked in brought them in for a site visit, like well in advance, level 1, level 2 trauma centers that you really, really want to see them and understand their skill set before you hand some of that off from a patient perspective. Because again, the locum doesn't live in that community. That surgeon does, probably for 20, 30 years of their career. And the one thing people will remember, some quack walked in and didn't take care of their patients. So I think you get out of it what you give. And so it is time consuming. I get it. I've been the person that wore all the hats from perm recruitment to temp staffing. But you just remember the ultimate thing at the end of the day is that patient cares.
It's in the best interest of organizations to think critically about this process. It's a funnel into their operation that doesn't exist without its fuel for the organization. And if we just covered demand's going up, supply is not keeping up, there's a propensity of people in this country that want this type of work. The large delivery organizations that can figure out a way to pull these levers as efficiently as they can are the ones that are going to succeed over the next 10 years of meeting whatever mission, vision, and values they have, which typically is serving the community, right? That's what hospitals are designed and organized to do. The ones that are fulfilling that mission are, I think, the ones that are going to be the most innovative and receptive to new workforce trends. And I think the trends are undeniable at this point.
The one thing I didn't do when I was employed by health system was to develop an internal float pool, essentially, right? Like internal locums or temp assignment work. It's not as hard as health systems or whoever it is internally makes it out to be. That would have been a really, really fun project. And I know there are some systems out there that have done that. And if you're always so worried about cost, can you figure out some mechanisms internally? Start with hospitalists, start with EM, start with those people that do the shift work and see, can you float them? Will they do that? We've been doing it for years with nurses. And physicians they're up for some of that because they're like, ooh, I get to see a new place. So that's the one thing that I would have loved to work on is to help health systems.
I think the macro labor trends are so undeniable that I don't think that there's ever going to be a perfect match for the supply side of the labor force versus the demand side on the delivery systems. I think there's always going to be a place for businesses like mine that have strong networks of specific, very focused clinical talent that is eager to move around the country, and we can put them in places that they're needed at that moment. I think that's always going to exist. But you said something that I believe pretty deeply, and it goes back to the difficulty of provisioning healthcare in this country right now. The profit margins on these hospitals are so small, they've all lost money the last 5 years. I think I saw a stat from Becker's that 50% of hospitals are still losing money after COVID. So every hospital you drive by, every other one's losing money, and they're relying on their days cash on hand and their assets to fund their operations. So it's a very difficult business to run. And as such, in a business that margins are really tight, the resources are constrained. Their people resources are constrained, meaning the people running the business, there's probably enough work for twice as many of them, 3 times as many of them. So when I was at UMS, it's about a $500 million hospital. There were probably 10, maybe for being liberal, 20 people that were truly running that business. And there were 3,400 employees. And 3,400 employees being managed by roughly 15, 20 people. Those 15 or 20 people are really busy and they make mistakes because the volume is insurmountable, but they can solve for labor issues if they focus on it. And one of the examples I would use to prove that is Baltimore, where I worked. It's a big city. There's multiple competing health systems. In places that we knew the supply chain or labor distribution in that center were vulnerable, like let's call it the cath lab, we would have a Rolodex of 1099 docs that could cover call. We would have an army of those people that were just on 1099. They're basically, you can pull that lever and put the bat signal out if something happened to your doc that was on call that weekend, and there was an option, right? Same concept of nurse float pools. But the ortho APP team, we didn't have the time or energy to develop that same infrastructure around that team. And so when 2 or 3 people would leave their maternity leave, somebody gets sick, somebody retires within a 30-day period, all of a sudden you go from 15 to 12. Boy, that's tough. So now I'm in locum territory, right? If we want to keep our operation moving at the pace that it's going to move, I better put somebody in. But to your point, I think the organizations that are doing this the most effectively are realizing this is a thing, and they're finding solutions and putting some of their management cycles focus on solving for these issues in their maybe most vulnerable cost centers. ED, hospitalists, cardiac surgery, CRNA. Like, I pulled a couple stats, in preparation for this, and this one was wild to me. From 2013 to 2023, the number of anesthetics delivered by CRNAs went from 35 million to 42 million to 50 million. And then if you look at the anesthetics delivered by the anesthesiologist, it's gone the opposite direction and dramatically. And we talked about retirement numbers in that field. They're making about 500 new anesthesiologists a year. When you offset it by the number of retirements, right? There's net new about 500 a year. So that's why you're seeing that shift, right? Where hospitals are going from maybe the doc is providing the care to medical direction, and then it's medical supervision, and then it's independent practice by the CRNA, because they're becoming so reliant on that labor force. That's an undeniable trend. So the most sophisticated and forward-thinking organizations are leaning into that and saying, all right, we have to figure out how to use anesthesia techs. We have to figure out how to use CRNAs. We have to figure out how to use and deploy these other resources because the market has demanded that we do it. So I'm impressed at organizations that are doing it well. And I really have empathy for the organizations that are struggling with it. You know, every hospital isn't in Baltimore with 5 competing systems that you can move talent around between. There's a lot of healthcare being provisioned in central Pennsylvania and South Carolina and Mississippi, where a hospital is out there by itself. That's tough. This is a tough business, and I'm really happy to be a part of it and be a part of a solution, but it's a zero-sum game. There's just not enough supply for the demand that's only increasing.
And in the example you gave, CRNA and anesthesiologists are a great example, because now you can't say we're moving to CRNA coverage because it's cheaper, because their compensation intersected, especially COVID, post-COVID, where they got really, really close to each other in comp. So you can't say the health system's sacrificing care, quality, or whatever by doing that in that example. And that typically with health systems, when they started bringing in more nurse practitioners or things in a primary care setting, it was like, well, they're cheaper. Well, should they be? Because if you can get reimbursed on the same thing that they do, guess who is coming out of school at a quicker pace to keep up with the demand? It is the APPs. And so I think that it's interesting you mentioned anesthesiology, because when those price points landed almost together, that wasn't a discussion point anymore, because you do have to pay for the talent if you want to keep the doors open.
Yeah, my wife's a PA. I work with a ton of CRNAs. I have tremendous respect for their skills and their training. I think most of them would be the first to tell you they're not physicians. They're just different. It's not one's better than the other, but they're different. They have different skills, different training. But the market and absolute macro trends are forcing organizations to utilize those skill sets in ways they haven't in the past. I don't think that those winds are changing. I think that this is the trend. 35% of primary care visits in this country are performed by NPs now. That's different than what maybe we're used to. Maybe it's okay. I think it's okay in a lot of instances. So it's just new and it's reality. And I think the organizations that are going to succeed in the next decade, both in the temp staffing business that's moving these labor forces around versus the employment organizations, the ones that are going to thrive are the ones that are going to lean into various employment models or income models. It's not technically employment, I guess.
And I think when you look across the country, since I spent a lot of my career in the West, I think the practice models and the integration there with other types of clinicians had to happen quicker because there were less people to go do and treat. And so when I moved to Tennessee, it was still like on the cusp. And it was interesting to me because I'd always lived in that integrated practice model or multidisciplinary teams that went around. And so for me personally, some of the best care that I've had is from those advanced practice providers, because they are operating at the very top of what they can do as a clinician. And I do think where you are in the country matters into how you have that access to care. The physicians have always been there. The day is coming when they won't be, unless it's some type of concierge environment or something else you've paid cash for.
Last question. You spent time on the delivery side, most of your career there, and now you're in a different space. Talk to me about what you're doing now and what role it's playing in this clinical labor market soup. And tell me about PracticeLink.
Yeah, so, PracticeLink serves physician and APPs primarily as a job board for the recruitment teams, in-house recruitment teams. They are able to leverage our technology and make those connections with opt-in candidates. Equally, we have other resources for them to outreach to providers. But the primary premise is that job board. And then for the provider side, really being a resource in their career journey. So we publish a biannual magazine called First Practice, just really trying to provide insights and education. We consistently hear they learn a lot about medicine, and as they should in school, but what they don't learn about is some of the finance, even the wellness pieces to take with them as they start their career. So we've really tried to support the clinician from that very entry point of finding their first job throughout that and being able to serve up those jobs on a routine basis for our clients. My role specifically as Chief Strategy Officer, really just helping the organization kind of reimagine and see where we go next. We have been a very physician-focused organization, so we are leaning into those APPs and how we can help our clients fill those positions because that market is just growing. And then equally, we talked a lot about partnerships, and then ROI is something I don't know that we talked about, but our clients are asking that. Like you said, the hospitals are floating on razor-thin margins. Everything is under the microscope. So how can we be the best recruitment resource in their toolbox? And then how can we provide them data that shows that so they can take it upward to their leaders and consistently show value to our healthcare clients?
There's a big need in the market for what you guys are doing. I joke and tell people all the time. We sit in the middle. Royal Surgical is a locum firm that specializes in APPs and CRNAs. We sit in the middle of organizations that are really busy and struggle to find talent, and talent that really struggles to have the time or energy to look for jobs. And the places that they look for jobs are wildly varied. So we try and bring a little bit of organization to a chaotic market, which I think is what PracticeLink is offering, as well as you guys are trying to centralize activity and connect organizations that are in need of scarce talent with scarce talent on their search. So it is a very interesting business, and we're happy to be a part of it.
Yeah. So I'm going to wrap up and thank JB for joining me today on the Workforce Wisdom podcast. For our listeners, please feel free to reach out with any thoughts or insights, questions you might have about what we covered today. You can email plmedia@practicelink.com. If you're looking for locum tenens position, watch for the Royal Surgical positions soon to be posted on practicelink.com if you're interested in finding career opportunities in the spaces that they serve. My name is Christy Bray, and I thank you for joining us.